In this video, I'm going to talk about surgical treatment options for chronic atrial fibrillation when medications and catheter ablation are not enough. So chronic long-standing atrial fibrillation becomes harder to treat because the atria are remodeled, stretched, scarred, and electrically chaotic. In this patient, surgery is sometimes considered, especially if symptoms are severe or if they're already undergoing heart surgery for another reason. So below are the main surgical treatment option. Number one is Cox-MAZE procedure, the gold standard for surgical atrial fibrillation treatment. MAZE 3 or MAZE 4. What it is? Surgeons create a series of precise scar lines like a maze in the atria using either radiofrequency ablation, cryotherapy, freezing, or surgical incisions. And these scars block abnormal electrical circuits and force impulses to follow a controlled path, restoring normal rhythm. When it's used, patient with a chronic or long-standing persistent atrial fibrillation, those already having heart surgery like CABG or valve replacement surgery. Effectiveness, 70 to 90% long-term success in restoring sinus rhythm. It reduces risk of stroke and heart failure progression. Number two, minimally invasive MAZE. It's called a mini MAZE. It's less invasive, performed through a small chest incision. What it is, a thoracoscopic procedure when surgeons create ablation lines on the outer surface of the heart, often includes pulmonary vein isolation and left atrial appendage closure. Who benefits? Symptomatic atrial fibrillation, patient not responding to medication, patient unsuitable for catheter ablation, and people wanting to avoid open heart surgery. Outcomes, 60 to 80% long-term rhythm control, faster recovery than full MAZE procedure. Number three, hybrid ablation. There's a catheter ablation plus minimally invasive surgery together, a collaboration between an electrophysiologist and a cardiac surgeon. Surgeon performs epicardial ablation, which is outside the heart. Electrophysiologist completes endocardial ablation, which is inside the heart. Best for advanced atrial fibrillation, large left atrium, multiple failed catheter ablation, and high stroke risk. Success rate is higher than catheter ablation alone. 70 to 85% long-term freedom from AFib. Number four, AtriClip or surgical left atrial appendage closure. Purpose, not to correct AFib, but to reduce the risk of a stroke. Why it's done? Over 90% of AFib related clot form in the left atrium appendage. Closing it reduces stroke risk when blood thinners are not safe or effective. Methods, atrial clip device, surgical excision, or stapling or suturing during open heart surgery. It's used in patients with chronic AFib and bleeding risk during valve or CABG surgery. Number five, AV node ablation with pacemaker. Not a cure, but helps with symptom. AV node is intentionally ablated, so it stops fast conduction, and a permanent pacemaker is implanted. Heart rate becomes stable, but atrial fibrillation remains in atria. Who benefits? Elderly patient, severe symptom despite multiple treatment, cannot tolerate medication, poor candidate for surgery or ablation. Limitation, atrial fibrillation continues does not reduce stroke risk, and you have lifelong dependence on pacemaker. Number 6, surgical pulmonary vein isolation, PVI. Surgeon isolates pulmonary vein to block atrial fib triggers. Used for early persistent atrial fibrillation when catheter PVI has failed multiple times and patient already undergoing thoracic surgery. So the question is, which treatment is best? Well, there are so many factors which your surgeon will decide, but it depends on several factors. Duration of AFib, is it paroxysmal, comes and goes, or is it persistent or long-standing? What is the size of left atrium? What are your symptoms? What is stroke risk? What is your age and what are the comorbidities? Had there been prior attempts at ablation? Is there a need for concurrent heart surgery? So all those factors are there. And you can really sit down with your cardiologist or electrophysiologist or cardiac surgeon. They can definitely have a team effort and decide what's the best for you. So in short, Cox-MAZE open heart surgery required. Cures AFib, success is great, 80%, 90%. Mini-MAZE, minimally invasive, controls AFib in 60-70%, does not cure. Hybrid ablation, combined ablation plus surgery, is meant for difficult AFib. LAA, which is appendage, closure of left atrium using atria clip, minimally invasive, is meant to prevent stroke. AV ablation and pacemaker using catheter to control symptoms. And surgical pulmonary vein isolation, minimally invasive, it isolates trigger, it does not cure. So these are the surgical options I wanted to discuss. I hope this is useful, and share this video, like it, repost them, and thank you for watching. TGIF, have a great weekend.